connection between the two. D is an injection of iodinated contrast material through the tip's needle to confirm needle position within the portal vein before passing the guide wire. E is transhepatic portogram showing opacification of varices, the transhepatic tract, and the hepatic vein. And then the last image is a portal venogram of the tip's insertion showing flow through the stent. And then the peripheral portal vein branches are no longer shown just because it's documenting also the reversal of flow. So in E you can see the varices over on the side, and then as soon as the tips is placed, in this patient it reversed.
Does this make sense? Because what that was just talking about it. Okay.
There's different ways of determining if the tips is successful. I just posted this just as an example. You can say technically it was successful simply because they were able to place the tips between the hepatic vein and the portal vein. Hemodynamically it corrected flow. Whether it corrected a variceal bleed or whether it corrected ascites. So there's different ways that they can measure the success of these.
Do they have a time frame on any of those? Does it happen?
Not in the articles I read.
You mean as far as gauging those kinds of outcomes?
Yeah.
Yeah, variceal hemorrhage,
Pretty immediate.
well, you almost always can control that pretty much immediately. It's kind of like when we embolize postpartum hemorrhages, you get rapid control. Plus, if they see big collaterals or big varices, sometimes you just go and embolize those at the same time to take them out so that those connections don't continue. Ascites control takes longer. You look for different pressure measurements across the shunt when we're treating bleeding versus when we're treating refractory ascites. You want a more aggressive control of the gradient with the refractory ascites. The problem with that is when you make a bigger hole, you can decompensate the liver, so you can put them into liver failure a little more easy. And so that's where it comes in, you take care of it. But usually within the first 2 to 4 weeks after tips, ascites comes under control, and they might become responsive to their meds, and then they can get weaned off of meds. That's what we look for.
Is that why you wait to do the tips ultrasound?
No,
following?
that's actually changed. That's based on the devices that are now used. When we first started doing it, we used uncovered stents because covered stents were not available, and it was all done with wall stents because we wanted a self-expanding process. And that wasn't an issue. You could do a follow-up tips the same day if you wanted. With the covered stents, the problem now is that they're coated in PTFE, which is microporous. So even though they fill and you bleed and they clot, there's air trapped in them, and so they recommend that you wait 2 to 4 weeks at a minimum so that all that micro air is absorbed so that you get a clean window to get in and see. So that's the new, and that stent now is called a Viator, is the one that they use on that. And it's a partially covered stent, so the end is uncovered, and then there's a zone that you can see as you're placing it that shows you where the cloth begins, and so that you can do that and land it appropriately in the portal vein. So, and that's the big reason, but that's a good question.
So, why would you do one the same day?
Well,
You
we
can
used
do
to
it for
because we could.
complication.
But like now, why would you? Well, I forget. I did one the same day. I can't remember why though now. Why
Maybe
would you?
there was some acute decompensation. You can see they're just not as pretty, but yeah, we usually don't do them on the same day. I don't know why.
Wasn't he,
If he couldn't remember which hepatic vein he
There was
was
something going on.
He didn't know for sure if it was
I
up
That
there or
wouldn't
the
make
middle.
any difference.
I remember that case, Tasha.
Yeah, I don't know why he would have done it. That's the exception. Yeah, usually
Wasn't he
you
concerned
don't
about a
stop
portal thrombus though?
What'd you say?
He was
yeah,
concerned
that's
with
what it
portal
was.
thrombus.
Oh, so if the guy did something and they were
Yeah.
concerned, then you could come in, then you'd look at the influence, make sure that there was just normal antegrade flow through the portal, and what your expected velocity would be. So, yeah, but usually that's one of those things you don't quit if you think you have a suboptimal result. So, I'm not quite sure what was going on. That's very odd.
It was the only one I've ever done.
Yeah, so
I
that's
didn't
very
know.
odd.
But I know that
Remember why I
I know
did.
the case wasn't pretty. I remember that, I don't still remember
Most,
why.
so as far as doing the procedure itself, they only go one of two ways. Either they go really well or they go for crap. And and on a good day, you can do it in about an hour. On a bad day, you can be down there for 6 hours.
Do you guys ever try to do like a pre-paracentesis or post-paracentesis?
Yeah.
With this idea of exposure?
Yeah, we often will tap it during the day and things like that, so.
All right, so ultrasound is the primary screening tool for tip stenosis. We're non-invasive, readily available, and relatively low cost compared to other imaging modalities. When looking at a TIPS, the typical velocity range is normally somewhere between 50 and 250 centimeters per second. Peak velocities below or above these can be associated with shunt dysfunction. And then flow direction of the portal branches should be evaluated. Pre-TIPS hepatopetal flow, so into the liver, will typically reverse once the TIPS is created. If it's going to reverse, I had talked to Dr. Miller about that, it'll do it nearly immediately, that's the pressure gradients. But it doesn't always reverse. So whenever we're basing something, we always look at the baseline ultrasound. So if it changes from the baseline ultrasound, that's when there's concern. So, and then stenosis develops. If a stenosis develops, the blood flow for the portal branches will revert back to its original.
So for like the velocities, like, your proximal, mid, distal, do those variant, like at the proximal, is it higher than the mid or?
Usually a little bit. There's a gradient there, and there's a velocity drop off that you usually see going across that. And that's why the baseline study is so critical, so that you know what you're looking at there. And then the next one, you kind of look and follow. Not only do you want to do that, but you want to look especially at the hepatic veins. Jess, I don't want to steal your thunder here.
No, you're fine.
The most common site of failure is at the junction with the hepatic veins, and so that's the area where we're going to look. So.
Right here. So, a venogram and the pressure measurements are the standard way for determining if a shunt is dysfunctional, although it's an invasive procedure, like Dr. Hackworth said. So, the venous end is the most common area for a stenosis. And then on this image, they had just put a stent across that to open it back up.
So, in that image is really very diagnostic to think about for what we're thinking about with ultrasound. That prelim is before they treat it, and you can see the stenosis up in the hepatic veins. You guys see that real easy up in there. So you've normalized pressure back in the portal system to what it was pre-stent, and you see, look at those big right portal veins over in there. So they've now got to integrate flow again because they're injecting down in the vein. Once they pop that stenosis up high, the shunt's wide open, so you lose loss of visualization of antegrade flow. They're not thrombosed, they've just reversed flow because your low pressure sump is now out through the stent. And it's just think about it as simple plumbing, and that's, if you just kind of think about this, I'm blocked here, if I do this, what will happen? And that's how we're looking at these.
So abnormal ultrasound findings that may indicate a stenosis can trigger a venogram to be performed. Some patients, if ultrasound isn't the best imaging for whatever the patient reason or whatever they're going through, if they're symptomatic, it can also trigger them to have a venogram done.
And that's usually recurrent ascites. All of a sudden, somebody says, my belly's getting big again.
Do you do those in special procedures, the
Yeah.
programs?
Yeah, but usually if somebody says, they say to the gastroenterologist, I feel like I'm getting big again, they'll send them over for an ultrasound first, and that way we can document that there's ascites and we can assess the shunt in there.
So, and like I mentioned before, there are variations to having the tips placed. So typically it's right from where the right portal branch comes off and it'll go into the right hepatic vein. It can be further out. I think Laura, a while ago, you mentioned one in the left side that you had scanned. So there are different variations to where those can be placed.
That was difficult, because I was looking for the portal vein branches, and it was not looking at all what I expected it to look like. So when I went to Dr. Miller, he was like, oh, well, I put that one in the left, so you're not gonna, but I was like, oh, that might have been helpful. I spent a lot of time looking.
Yeah, I think that's one thing too, is to always, if you have a question, just pull up, especially if it's the first one out, pull the venogram, because you should be able to read on there what they've
What they
connected,
put it in.
and far as that's concerned. Now, the other thing that you'll see too is people, when they first start putting these in, they tend to put them in more peripheral than they need to be. And that's a hard thing for people to learn until they have a couple of them where they screw one up and they see, oh, they understand why the old guys always tell them to don't go so peripheral on it. But they can get this funny, really hook shape. And you want as simple, so the simple laws of plumbing are shortest distance, biggest hose possible. So you can see on those, you see how they're nice and they're straight, there's not a lot of curvature to them, but sometimes they'll get way out in the vein and get it, and then those are the ones that are at a greater risk of failure, because there's more of the hepatic vein outflow that's actually in those native cells that can then hypertrophy in relationship with the turbulence. So I wish they all looked like that.
We do too.
Yeah, I know.
Will those velocities be lower then, because they have more of a curve?
No, in fact, sometimes, you can get that curve and you can get that funny aliasing on the edges because of the way they look in there. It's like a bad carotid.
So for our TIPS protocol, we only need to be doing imaging of the liver, which I think some of us have been all over the board there. But imaging of the liver, rule out any regenerating nodules, masses, irregularities in the hepatic echo texture, and irregular liver surface. These patients are typically cirrhosis patients. They have an increased risk of HCC. We follow up normal liver Doppler protocols with the addition, we follow our normal liver Doppler protocol with the addition of at least 3 Dopplers in the tips. So at least proximate and distal, more if needed, and then also evaluate for ascites.
I will tell you that I want you guys, and we're going to talk about revising this as well too. I agree with this. I still think sampling in the splenic vein just for direction of flow is of value in these situations. It's really quick and easy to do, but that then also confirms that you have correct direction of flow.
Yep, and then this is just again a list of our normal Dopplers. So the main portal, the right anterior portal vein, the right posterior portal vein, the left portal vein, hepatic artery, splenic vein, hepatic vein and then splenic vein.
Do you really care where we put our spectral for our splenic vein?
No, just as long as we can see the main direction of flow. So if you're out in the pancreatic tail and you can see it well and we know which way you're oriented, I just want to know whether it's going towards the spleen or back towards the liver.
Right.
Ideally, if you got reversal of flow in the splenic vein, then we've got problems upstream, and it's just a confirmatory to say, okay, I'm seeing this. Oh, you got this downstream here, and we can move from there. The other thing is, remember on TIPS patients, cirrhotics have abnormal hepatic arterial velocities. They tend to be hyperdynamic. They can have internal shunts because of their liver disease, so they can get these funny waveforms. So don't be surprised. You're going to see more hepatic arterial velocity abnormalities, especially in TIPS patients.
And then for these as well, if you're doing the splenic vein and you do go to the left upper quadrant, like when you're looking for ascites, we don't need spleen measurements at all. It's probably going to be enlarged since they have a history of portal hypertension. So then just some images. This was all on the same patient. This was the practical part of the tips coming through. This is one of them that curved around. And then coming mid, including your velocity on each of these. Distal down low. And then this one was nice because it actually showed where the tips went right into the IVC. And then you could see it in the grayscale images as well.
So can you go back one, Jess?
Yep.
So the other thing there that you're always looking for when you're looking at portal veins and hepatic veins is you have reflected cardiac waveforms and phasic variation with respiration as well too. You want to see those because you now have an open circuit. But if you get a hepatic vein stenosis that's proximal to your tips, that will choke off flow. So you're getting increased pressure behind it. So you'll lose that phasic variation because the reflected cardiac waveforms can't get back down to you there. Does that make sense? So you might still have correct direction. You might notice that velocities are coming down, and you get it, and then you get that uniform waveform, and then you say, oh, that makes sense. And then you're going to be looking harder at the hepatic veins and say, oh yeah, there's a aliasing zone or there's a stenosis that I can see.
So for what we're looking for on these ultrasounds, like I said, rule out liver masses. HCC is common in these patients with history of liver cirrhosis. Evaluating the tip's velocity, a change in the velocities from the baseline, and then stenosis is most common at the hepatic venous end of the tips. So you're looking at the velocity, also looking for reversal of flow in the left portal vein, primarily a reversal from the baseline direction, so that baseline ultrasound that was done shortly after placement. And then most asymptomatic patients will be followed at regular intervals using ultrasound with Doppler. Here at Aspirus, talking with Dr. Miller, typically 2 weeks status post tips placement to get the baseline velocities earlier if there is a concern for it, following by 6 months, 12 months, and annually if the patient is asymptomatic and the scans remain normal. So then with the abdominal Doppler, we also included renal arteries. And then just
So, actually, now, and, sorry, Jess.
Yep.
Typically they should be NPO patients for our tips.
Yeah,
NPO.
because you want less gas artery
Yeah,
for
but,
your
yeah.
window to get in. You know.
So anatomy of the renal arteries. The right renal artery is the anterior lateral branch from the aorta, and it courses laterally posterior to the IVC. The left renal artery is a posterior lateral branch, courses laterally, and the hepatic veins are found anterior and parallel to the renal arteries.
How many renal arteries are there in Yeah, usually one to each kidney, but renal artery, accessory renal arteries are, I've read some papers as high as 25% of the population. And I can tell you from reading CTs, that's probably true. So they're as bad as thyroid nodules. So just think about that. Whenever you see that, and especially if a vessel looks small to you, start looking for a second.
So just a diagram showing the course posterior to the renal veins. And then how the arteries branch off. So the main renal artery comes in, divides into the segmentals, then it goes to the interlobar, the arcuates, which arch over the pyramids, and then the interlobular. And then an ultrasound image of them.
And all of yours should look like that.
Absolutely.
Yeah, but
I
the
expect
scale,
it.
but the scale should be turned up a little bit more,
So, and then the article I read actually said approximately 30% of people have one or more or duplicated arteries. And then for those cases, each renal artery needs to be evaluated.
So the practicality of that though is once renal arteries are 4 millimeters or less in size, we don't do anything about it even if they have stenosis, because intervention, even using cardiac stents and that are designed for smaller vessels, we've not proved that it's really of any value. So we'll document and do our best, but don't sweat it. you know.
If they have more than one renal artery to their kidney and stuff like that, if one's stenosed, wouldn't the other two theoretically pick up the?
No, it doesn't always work that way.
So the reason we do our renal artery studies for renal artery disease, so it's a buildup of plaque in the arteries that leads to the kidneys. It's the same as the atherosclerosis effect for the peripheral arteries, and it causes the arteries to stiffen and narrow, impairing blood flow to the kidneys. And the most common area for stenosis would be the proximal part of the renal artery, so branching right off of the aorta. Indications for a renal artery stenosis Doppler: persistent or severe hypertension, not controlled by medication or lifestyle change, abdominal bruit, fluid retention, congestive heart failure, and kidney failure in severe cases. And then risk factors are patients over 50 years old, diabetic with high cholesterol, a history of smoking, high blood pressure, family history of coronary artery disease, peripheral arterial disease, or renal artery disease, fibromuscular dysplasia, and neurofibromatosis. Ways for testing for a renal artery stenosis: abdominal duplex ultrasound, MRA, CTA. There is a nuclear medicine scan that they're able to do, and also an angiogram.
I will happily tell you that I've not done a captopril scan since I came to this place in 1997. So that's it, put up for historical. The other tests are done, just not as frequent. The CTA is probably the most common way that we screen renal arteries in this institution.
So our protocol, our prep for these patients is to be NPO 6 to 8 hours prior. And then we do spectral and color Dopplers on the mid-aorta, measurements of each kidney, approximately 3 images scanning through the kidney and sagittal just to document any masses or abnormalities, spectral Doppler of the interlobar arteries, spectral and color Doppler of the superior, mid, and inferior segmental arteries, and for these you'll look at the acceleration time. Spectral and color Doppler within the proximal, mid, and distal main renal arteries, and then repeated on the opposite kidney.
And of course, you can see all of those vessels beautifully.
Yeah.
Absolutely.
With perfect angles.
So, just going through the protocol, Dopplers of the mid-aorta. This is done just proximal to where the renal arteries branch off. And actually, these images were all done on the same patient as well. It was an inpatient with refractory hypertension.